I'm Margaret Laws, Director of the Innovations for the Underserved program at the California Healthcare Foundation. Primary objectives of the Innovations program are to develop and promote lower cost models of care, to improve access to specialty care, and to increase efficiency in the safety net. Telemedicine can be a powerful tool in achieving all of these objectives. The short video that follows explores telemedicine programs in several safety net clinics in California. It highlights the access problems these clinics and their patients face, the ways that telemedicine has been able to meet some of these access issues, some of the barriers and challenges clinics have faced as they've implemented telemedicine programs, and what we all believe is the real promise of telemedicine to improve access and patient care in California's safety net.
Telemedicine is the use of telecommunication and information technologies for the provision of health care at a distance.
One out of every 8 Americans lives in California. California is divided into urban, suburban, rural, and frontier. Many parts of California are frontier.
People live in small communities separated by miles and miles of roads. It can sometimes take 3 hours to get from one corner of the region to the other. There may be a system of primary care clinics or rural hospitals, but specialty services, those like cardiology, psychiatry, are very difficult to provide in these small, isolated communities.
You're not going to probably find a pediatric endocrinologist if we recruited now till the cows come home, up here in Redding.
Most telemedicine programs to date have taken place in rural areas, but what we're seeing is that urban underserved areas can also benefit from the tools of telemedicine.
It is not unusual when we refer a patient to a specialist for them to have to take 2 and 3 buses to get to that visit. And when you think of yourself as having children trailing you and trying to get to an appointment on time and navigating a very complicated system, then you begin to see what a difficult situation is.
Specialty care is limited in California in terms of the number of providers. That is even more limited when you look at the number of providers willing to accept low-income patients. Telemedicine can help redistribute knowledge and expertise, and therefore it gives you a bigger pool of people that you can potentially connect with for specialty services.
Most people who teach doctors say that you get 90% of your diagnostics by history taking. So most of it's talking.
What telemedicine does more than just video conferencing is that a variety of other technological tools can be added to either end of that teleconnection to give information to the medical provider that is necessary in making a diagnosis.
Can you get a little more light on it?
We can transmit data, we can transmit really close images of skin so that the provider who's at a remote location can get as much clinical information as possible and make a good judgment.
Often with these cameras, I will tell the clinician.
In order to do telemedicine, the rural provider needs to have telemedicine equipment, video conferencing equipment. They need to have high-speed telephone lines that help send a very clear and secure signal.
On the specialty provider side, the requirements are relatively minimal. You need a room that is relatively soundproof, a reliable broadband connection, a monitor, and a camera.
So how's the diabetes going? It's doing a lot better.
Not only do we see telemedicine as the solution to accessing healthcare that our patients might not otherwise have access to, but it's also a way for us to improve our own learning curve.
There have been a number of times when I've been stuck with a complicated endocrine problem. I can remember a couple of complicated thyroid cases, and there's no endocrinologist locally. So my patient could see the endocrinologist, and then it was educational for me too, because I came in at the end of the visit, finished up the plan, and was able to ask her questions about how she came to those conclusions.
In our work with safety net clinics, we're focused on how to optimize the use of scarce resources. Telemedicine and telehealth can help us do that.
Having a large prenatal program means that very often our providers are called away in the middle of the day to go to the hospital to stand by for a delivery. We are now connecting to the hospital, and the provider will be able to see the patients that were scheduled that day. This is a much bigger issue than most people realize. Last year when we did a count, we had one provider where we actually rescheduled 1,000 visits during the year.
The biggest challenge, I think, is coordination. You're trying to get a patient in one place, a specialist in another remote place, and we often use another clinician here with the patient.
If the consultant gets called away or if the connection breaks down, you've invested all this time and energy and you've got nothing to do.
There is limited need to have the specialist actually in the same room with the patient for many conditions. And really, it's about accessing that specialist's expertise, bringing it to the patient, and allowing that information to be customized to that patient and their overall health conditions.
So an example of that is called store and forward technology, where the rural provider can take a picture of a skin lesion that a client may have, zip that up into a secure file, send it over a phone line to a dermatologist, and that dermatologist can look at that skin lesion anytime, day or night. They don't have to necessarily talk to the patient because they have enough information from the history, physical files that have been sent, and the picture.
The infrastructure is not yet as good as it ought to be. And the quality of the transmission has a huge impact on the satisfaction level of both the providers and the patients. One of our biggest problems on the North Coast is that we have one fiber optic connection, and in this past year, it's been cut 4 times.
In the 50s and 60s, we built a highway system in California that got better and faster and reached smaller and smaller communities. And now we're talking about a digital highway that is networking the entire state and can be a tremendous benefit for providing health care throughout all those areas. But in order for that to occur, we need to have a network of both hub and spoke sites that are all linked together in an efficient way to coordinate the care across that network.
A hub site is someone who provides the specialty services to other clinics. Spoke site is the site that is asking for specialty services. As a spoke site, we seek specialties in pediatric endocrinology, pediatric neurology, and several different types of psychiatry specialties.
We're able to use our specialists to provide services to outlying clinics. Our partners now include clinics ranging from near the Oregon border down to the Central Valley. So it's becoming a network of exchanging specialty services.
For me as a telemedicine coordinator, watching what telemedicine has done for our patients that can't travel 4 hours for an appointment, they can't afford to be off work for 8 hours or 12 hours. Telemedicine allows them to get the quality care that they need for their children.
I think for technology to be utilized to its fullest potential, all of us, clinical providers, patients, policymakers, regulators, we all need to take a step back and really look at how we can use the tools available to us today to really redefine the healthcare encounter to allow technology to play a role in facilitating access to care.